And we have two directions for discussion. First of all, get know the details of DB05, look at the data, the values, and have our comments. Then for second part, look at DB11, the addition of ADC in an AT setting. Then based on the two studies, for HER2 positive early breast cancer, how to leverage those new therapies. There are 5 questions raised, and the first 3 are about DB05. The data from DB05 is really good, especially for high-risk population, how to position this. So the first question, DB05 data was shown in ISMO, so this included more high-risk population. If you remember, for Catherine, the 3-year was 77, now it is 88. And then in DB05, over 50 are T4 and 3 patients who cannot be operated. 78% were treated with dual targeting therapy, but in Catherine it was only 20%. So these are high-risk population. They used intensified therapy. They do not have PCR. TDM1 group was 83, now 88, and for T-DXd, this is above 90. So in our practice, should we find patients who have higher relapse risks, who respond poorly in NAT? So we should treat them with T-DXd in adjuvant therapy, or the data is so great so that after dual chemo and dual targeting, we can use T-DXd to replace DM1. So is that related to our relapsing risk? Professor Li Huiping, would you like to comment on it? Right. For DB05, it's really great data. We were part of that, and we contributed 30 subjects. We understand this drug. Here's my take on it. And I look at the paper, and how do I feel it personally? I read the data, and radio pneumonia is high in T-DXd group is 28%, in the control arm is 27%. So under such circumstances, if it's a high rate of radioactive pneumonia, of course there were concurrent radio or sequential radiotherapy. So under this scenario, for high-risk population, we treat patients with higher risks with T-DXd because you bring side effects like pneumonitis. And for patients in this group, they have a higher risk of ILD. Whether it's NAT or adjuvant therapy, you know, so safety should go first. We need to be careful. This is my take on it. I'd like to ask Professor Geyer's points. You know, why concurrent radiotherapy and sequential radiotherapy were allowed? For sequential radiotherapy, HR was 0.35, and for concurrent radiotherapy, 0.55. So this could avoid ILD if you don't combine T-DXd with radiotherapy. So in the future, should we have some minor adjustments for this? Thank you, Professor Li.
So, Dr. Gill, can you understand the questions? I think the 2 questions are focused on. The first is, based on all the data, we should select high-risk patients to use T-DXd, or just every patient who is enrolled, and we can also use T-DXd. And the second is why we designed to concurrent or sequential use with the radiotherapy. And any comments about this treatment strategy?
Yeah, in regarding the radiation therapy, you know, it is interesting. The point estimate does look to be substantially lower with the sequential, I mean, better with the sequential than the concurrent. It's hard for me to imagine that what the biologic basis for that would be, why efficacy would be enhanced by delaying the T-DXd while you do radiation therapy. But, I think if somebody's going to look at the data and say, well, which one am I going to do? Why not do the sequential approach and avoid? My prediction is a lot of sites will go to the sequential approach when they look at the data. The point estimates there, we thought we might see some difference toxicity wise, but that really hasn't been borne out, and that was the main concern. Obviously the effects of radiation therapy continue, and when you're doing sequential, you are still overlapping. You're not treating, but you're still recovering from the radiation therapy. The other thing about that I think that was very important about the study is we knew we would see radiation pneumonitis. We were going to get CT scans so we could quantify it, and we had the control arm of the TDM1. And on this protocol, if it was clearly radiation pneumonitis, localized to the radiation fields, asymptomatic grade 1, we treated through that with the drug. If they got to grade 2 where they were having symptoms, then you treated hell, but you could go back to it. So we really tried to identify the radiation pneumonitis and approach those patients differently because we knew we'd see it. And my take of the data is, yeah, it's there about 25 to 30% of the time. Fortunately, it's generally asymptomatic. That's something we're just finding out because we're doing CT scans, and it didn't get worse. We didn't stop the drug. It didn't get worse. So that's, for me, offers some reassurance. If you have symptoms, then you can pause. We did not see any of those go to grade 3 or grade 4 in spite of treatment. So for me, there's reassurance that if you see radiation pneumonitis, which you're going to see if you get CT scans, you can follow the way we did it on the protocol, and it doesn't look like patients will be harmed. The ILD question, though, is clearly continues to be the big issue because it was 10%, and we were pleased that most of those cases stayed grade 1, grade 2, and appear to be recovering. But it is a situation, a risk that I think will kind of keep us using this drug in the higher risk patient populations. And the other question that's out there that I think everybody had that question: do we really need 14 cycles of TDM1? But it seemed to answer that, knowing we were looking at T-DXd and we probably have this other information. I think that's a huge question. Part of what we are looking at very carefully in DB05 is the time to onset of the toxicity. How many of these were occurring, after cycle 6? Can you shorten it? Can you maintain the efficacy, lower the toxicity with shorter exposure? The DB11 with 4 doses does appear to have a lower rate of ILD, but it's not 0 even with 4. So there's still that question, and those patients hadn't yet had the radiation therapy. So how much that's really the question. The radiation therapy, the drug toxicities really do unfold over time. So you have to really look at over time and look at the recovery. And I think it will be, important when we look at recovery to see how recovery might differ in different populations. Is it a bigger problem? Like we saw, thrombocytopenia in Asian patients was a bigger problem than in other populations. Where does ILD stack up? Recoverability of ILD. These are all things that I think we need to have the information so we can make the informed risk-benefit decisions with our patients.
Okay, thank you for your answer. So the further question is, if we concurrently use radiotherapy and T-DXd and the patients have the symptom, and you mentioned we'll stop. So you will stop T-DXd or stop the radiotherapy or both of them?
Well, we were specifying for the T-DXd and the protocol. and leaving that radiation therapy decision up to the radiation oncologist. I mean, usually the radiation pneumonitis is appearing afterwards, so that you're past the radiation by the time that's showing up. I'm sure there were some patients that might have been at the very end, got their first scan with concurrent and saw it, but we didn't specify how to handle the radiation therapy in the protocol.
Okay.
We left that to the radiation oncologist's discretion.